Are you getting any image? So this is the right nostril, and this patient has a chronic cystitis, and our plan is to do an endoscopic DCR. Okay, this is the picture after decongestion knife. See in the DCR, the area of interest. Okay, pedal, divider pedal, divider pedal, cautery divider pedal. Knife यार 15 number. So the area of interest is this anterior part of the nose. Now there are certain landmarks which you can see at this point which are important. This is the middle turbinate, and see the uncinate process behind in the middle meatus. That is the uncinate process behind. This is the inferior turbinate, and this prominence anterior to middle turbinate going up, that belongs to the nasolacrimal system. So our goal is to open up this system and marsupialize, and our technique involves, I am going to raise it. See, if it is done properly, this is one of the surgery where you can give almost 100% results. Yeah. So I am going to make a rhomboid shaped flap based posteriorly, posterior shaped flap. So my incisions for the flap are, this is inferior turbinate, this is the nasolacrimal system. So my incision starts inferiorly, right from there to anteriorly here. This almost 2 centimeter incision posterior to anterior, just above the middle turbinate. Now same incision posterior to anterior will extend. See, this is axilla, just above the axilla, because the dome of the sac, the lacrimal sac, extends sometimes above the axilla. See the same incision anteriorly as well. And now I am joining these two incisions anteriorly like this. Can you see this? So this is a posteriorly based rhomboid shaped flap, वो लगाओ ये वाला section पे, which I am going to elevate now. See, you can easily elevate this flap. Yeah, this is a suction elevator. You can simply elevate this flap and push it posteriorly. Scissors. अभी लाए ने. That's the prominence of the nasolacrimal duct. How is the picture there? Okay, I will evert this flap like this and push it medial to the middle turbinate. Now, why did we raise this flap? Because I am not just going to open a nasolacrimal duct and leave it. It may re-stenose. So I am going to marsupialize it completely, and I want the flap mucosa should fall laterally, छोटा करो, onto this raw area. काटो इसको, इससे काट लो. So let's decongest the area completely. Clean the area with the marrow cell. See that once you mop with the marrow cell, the bleeding will go away like a magic. You can cauterize, simple. Here you won't find any significant bleeding for that matter. Sometimes you may have oozing from the mucosal margins. Either have some patience or just apply some cautery लगाना. मेरोसेल देना. इसका एक तो 1/3 कर दो. इसको 1/3 एक तिहाई. Identify. Difficult to? Yeah, that's what I'm showing you. No, nothing works. It's not a sinus disease for which all this is required. Touch करो. Okay, now this is the nasolacrimal prominence. Carry some. Now the first thing is, like you said, if somebody asks how to locate the sac, carry some punch यार. एक जना सिर पकड़ना पड़ेगा यार, उधर से अलग. So, our approach is not to look for the sac first. Our approach is simple. See, this is the nasolacrimal duct prominence. Go behind it. With Carison, punch out, and you are right on the nasolacrimal duct. Can you see? In the first go, you can be right on the system. If you find a nasolacrimal duct, see that duct? If I press, see that? If you find the duct and follow it up, it has to lead to sac, nowhere else. So no point in looking for the sac here and there. Just find the duct below and follow it up. Yeah, just 2 mm Carison punch. See this? And now keep following it up. And march supply not only the duct sac but the entire nasolacrimal system. It will never re-stenoze. Pardon? Yeah, you can use power instrument, you can use drill from the microdrill, but generally I reserve the drill for the upper part in case required. Sometimes in the elderly patient. See now, I'll tell you the trick how this complete bone comes. Slipping, this is not mine. अरे मेरा Carison देना. See, if I am not using my Carison, yes, that you have to have a trick. Like engage this, hold this tightly, don't bite through, and then rotate. See, this Carison is slipping. मेरा पड़ा ना उसमें Carison. किधर? No, straight one. I'll show you with my Karl Storz Carison. Amazing. It will hold the bone perfectly, and then you can rotate, and the entire chunk of bone comes in one piece. That saves your time and energy. See the nasolacrimal duct? I generally open wide and wide, whatever possible, so you can marsupialize a bigger portion of the duct. अरे नहीं Carison थोड़ी ना यार, क्या लिया है तू? ये ऐसा गुरु, ऐसा लाना सीधा. है pre-op, that is to reach to the correct diagnosis. That is diagnostic part. Hard is good. Soft is means there could be common canalicular block. So soft, if you have, get the DCG done. पकड़ना. See, this carries some slips. See my Carl Stores one. Hello? तेरे क्यों कहा था लेके? 1 lakh. This costs 1 lakh. काले के लिए चल रहे थे अपने 3000. See this big chunk of the bone of the entire nasolacrimal system has come. That's the beauty of this keratin. The straight black. So one piece you can remove. Wonder karo. सेक्शन लगाओ. बंद कर दिया क्या? सेक्शन लगाओ अपना रेगुलर. Not getting any image? Now can you see the entire duct and the sac? Now what is there up here? This is Agarnese. That is Agarnese cell. Agarnese is what? Periosteum. Ethmoidal cell. Ethmoidal cell pneumatizing the lacrimal bone. Now I will increase the decompression behind as well. See this? So this full circumference of the nasolacrimal duct now is in view. Can you see? Decompress. So I will completely marsupialize this. See like this. Debrider. Straight. So now see the completely marsupialized. I will now extend my marsupialization little more anteriorly here. Superior extent is very nicely done with the single chip of bone. That's I prefer this particular keratin. Yeah, very rarely, particularly males and with good build. Either be patient, remove slowly or use the powered instrument. You can use the drill from the Medtronic micro debrider. See now? So now I have a full exposure of this duct as well as sac, and this is the agar which I am opening. Can you see the agar cell? Anyway, I am very particular about the superior exposure, because if you go particularly superiorly, you rule out the possibility of restenosis by looking at the common canaliculus from here and marsupializing in that region properly. Look again, Sevlon. Sevlon. Sevlon mangalo. So now this exposure part is done. You can see. I have done. See the superior exposure. Yes. Yeah, I have gone up to the superior part of the sac. That's what I told you. See, I have gone to the upper limit of the agar. Upper limit of the agar. Can you see? See this entire system more than 2 centimeter in length. See this? It's completely marsupialized. क्या किया? Now my next aim is to open the sac and marsupialize it. नहीं पहले वो 12 number, तो 15 number here. Generally I use the 12 number knife, but here I am using the, can you see 15 blade? No, I am going to marsupialize both sides completely. See this? Pull and discharge. See, फारूक, यहाँ से एंगल वो होती है ना, ऊपर तक आराम से चल जाती है. See that? See the pull and discharge in the sac? So simply I divided it. Now I am going to marsupialize it. The marsupialization, this is the superior cut on the posterior flap, and this is the inferior cut on the posterior cut. Okay, and you can marsupialize it behind. See behind what I have done. I have made the surface raw to take this flap and allow it to adhere there. Okay, see this, without any tension this flap is going to lie down so easily. See that? That's the interior of the sac. Look, right angle, right angle, pick. फारूक, वहां से निकाल के लाया था ना यार वो राइट एंगल. अरे पिक होती ना स्ट्रेट, राइट एंगल पिक. फारूक देना. Now what to do with the interior flap? See that? For the interior flap, see this is posterior flap.
Yes, sir.
This is the lumen.
Yes, sir.
Now this is posterior flap, anterior flap. See, I am using the autology sharp right angle.
Yes, sir.
This is not very sharp here. लो सिकल कहाँ हूँ, इसको रहने दो सिकल. Can you see that?
Yes, sir.
And similarly for the upper part. And this flap is coming here anteriorly like this. Can you see that? Now the entire duct is marsupialized. See,
Yes, sir.
on all sides. See the secretions. No, वो दो section. All secretion there. See this purulent secretions. Can you see the sac completely?
Yes, sir.
See both flaps on both sides, lying without any tension.
Yes, sir.
And if I stabilize these flaps, they were never going to come back. See this?
Yes, sir.
See the lateral wall. Ultimately, after 2 months, you will see more than a centimeter wide opening in the lateral nasal wall, which is never going to close. Give me gel form. Gel form चाहिए मेरे को. Now, रहने छोड़. फारूक छोड़. जरूरत नहीं. Now this is my flap. See what I am going to do. I will divide it into two horizontal flaps. Okay, the lower is going to come here and upper one is going to go come there superiorly. Okay, now see what is going to happen. See that now. No raw area left now. And see this
Yes, sir.
nasolacrimal system gel form. Gel form, गुरु ये मेरो सेल है ना एब्जल. So finally I will just reinforce these flaps to their place so they do not fall back. See that? No bleeding. Such cases do not require any nasal packing. Next day onwards, straight section, we start the normal saline irrigation. And right now I am using the various gel form pieces to stabilize these flaps in their place. So you can imagine this kind of a opening in the lateral nasal wall. See that? Big opening, and that's what I want these flaps to remain in place. And the simplest way is stent. We never use a stent. Why? This. See, the fault in the technique cannot be covered by the stents. So if you do it properly, why do you stent? Do you find any need of using stent now? The stent, no question. Sometime in a very fibrous, thick sac, repeated, revision, operated, ऐसा ही कर दे दो. You can think of sac, but even though sac, if you use the stent, itself becomes a big problem. See this one piece of gel form where I am using. I will remove it back. this one piece of gel foam I am using to stabilize my,
posterior flap.
yes, this one settle down with the blood. See that?
Yes, sir.
Since the posterior surface, both raw areas are in contact, the outer side of the sac
Yes, sir.
and the bone underneath. If they remain in place for a day or two, the adhesion forms. Okay?
Yes, sir.
Similarly, for the anterior part of the flap, can you see?
Yes, sir.
So, this is very, very important part. And see the sac.
So you don't do syringing intraoperatively?
Yeah, in case I have a doubt there is too much of thick discharge,
Yes, sir.
then only here it is so clear cut. See now? This is to hold the anterior flap. Okay?
Yes, sir.
और दो.
The gel foam will lead to adhesion.
Yeah, this will keep the raw surfaces in a position.
Yes, sir.
The blood and the gel form is going to act as a glue. Now this piece for the upper part of the flap. See that upper part of the flap?
Yes, sir.
This will remain stabilized with this. Okay?
Yes, sir.
See nicely, this the flap is there. And lastly, for the lower part of the flap, and that's it. That is just above the inferior turbinate. See this? The main flap is divided into two, upper and lower.
So, sir, do you remove the gel foam after a few days or it gets absorbed?
Yeah, I'll let it absorb.
Okay, sir.
No need to remove this. See, this flap will remain in position.
Okay, sir.
Next day only we will start the saline irrigation.
So when do you start the saline irrigation after surgery?
After this,
40 days.
after this surgery,
Yes, sir.
ask the patient the plain saline irrigation, okay, and keep pressing in the lacrimal region frequently with the finger, and call them after a month. See this nasolacrimal system?
Yes, sir.
This is the posterior flap gel form. See, after getting soaked in the blood, how they behave. See? See the glue. Acts like glue. There's the posterior flap. This is anterior flap. This is flap on the inferior flap, this part, and that is superior part. And that's it. Forget about it. Thank you so much.
Hello, sir.
Yes, sir.
Sir, there is a question. After how many days you do lacrimal syringing?
We don't
Is
do.
it needed?
Not needed. Not needed. Just.
Syringing is not needed.
So next cholesteatoma case is getting ready. So it's probably a case of atic cholesteatoma.
Okay, thank you, sir.
In 5-10 minutes we'll be back with the case.